Welcome to the podcast on assessment and management of type 2 diabetes in older adults with complex care needs. This podcast was created by Melissa Aslagi at the University of North Carolina, Wilmington, based on content authored by Ms. Kathleen McDonald and Dr. Deanna Gray Maselli. It will be presented today in a dialogue with Ms. Vanessa Jefferson. Ms. Jefferson, would you like to introduce yourself?
I'm a certified diabetes educator, and I'm a nurse practitioner. I work both at the Yale School of Nursing, and I teach in the diabetes concentration. I also work at the Yale University Health Service as a chronic disease manager.
So we'll begin our discussion today. Maybe you could just give us a little background about what diabetes is.
Okay, well, it's a metabolic disease, and basically it's characterized by hyperglycemia or high blood sugars. There's either a defect in insulin secretion. So I like to say that if you visualize a cell and you visualize insulin as a key, and so there's a defect where there's not enough keys to open the cell to allow the glucose to go into the cell. Or there's a defect as far as insulin action, so that there's plenty of keys or insulin around, but there's something blocking the passage of the key so that it can't get into the cell, or the insulin can't get into the cell. And because of hyperglycemia, it contributes to complications, so it affects every organ of our bodies. Sugar, high glucose levels surrounds every organ, so it affects our eyes, our kidneys, our nerves, our heart, our blood vessels. And therefore it leads to many complications if not well controlled. Well, first there's type 1, so that's like an autoimmune disease, and there's beta cell destruction. So there's a lack of insulin available. Patients who develop type 1 are dependent on insulin therapy. Type 2, it can be a lack of amounts of insulin, or it can also be a resistance to insulin, as I spoke of before. And so usually type 2s may start off where lifestyle, diet, and exercise can control the hyperglycemia that persists. But eventually, patients will require oral agents, and because of the beta cell just sort of pooping out the natural effects of aging, will require insulin if they do live long enough, most patients. And as far as the diagnostic criteria, this criteria is soon to change. In July, Diabetes Care is going to have a report using the A1C as the diagnostic criteria, as opposed to the criteria right now based on fasting, blood glucose, and so forth. And so I don't know exactly how it's going to change, but right now it's going to be an A1C greater 6.5 or greater diagnosing diabetes. Well, one other thing I just wanted to say, the reason that it's probably taken so long is because internationally the meaning of the A1C value wasn't quite the same. So now it's standardized throughout the world. So that's why they're using that criteria. In 2009, they'll come out with the article. But even if you go to diabetes.org, you can see it right now, a smaller version of an article. And then in 2010, the guidelines will definitely, the clinical practice guidelines, the supplement in January will definitely change. Okay, so the natural physiology of the beta cell, as I said, as we age, it sort of doesn't function as well. And so that's why there's an increased prevalence with age. And, it's twice as prevalent in women than in men. And I don't know if that's quite based on women being maybe a little heavier than men, possibly, not quite sure.
Or living longer.
Or living longer than men. 8% of our population have it, 23.6 million are diagnosed. And then we see that with prediabetes, there's 57 million people with prediabetes. But the nice thing with that, we've had some wonderful diabetes prevention studies, the diabetes prevention program here, and in Finland, a diabetes prevention study, and even in China, there was a prevention study. So they show that with a low-fat diet and a 5 to 7% weight loss and 30 minutes of exercise 5 days a week, that people can actually prevent or delay the onset of diabetes, which is a good thing. So there is a large population with prediabetes, and it's the third leading cause of death, unfortunately. By 2050, there's going to be an additional 18 million people who have diabetes, and unfortunately minorities are disproportionately represented, and you can see that here. And we can see that African Americans have the highest rates. However, if we were to eliminate from the Native Americans, Alaskan Natives, the Alaskan Natives, Native Americans actually have the highest rates of diabetes. So it's so important for students to be culturally sensitive and to find education materials that are appropriate, and also to think about how they discuss various aspects of diabetes, regarding food and so forth with their patients. But there's excellent sources, like diabetes.org has specific education materials for different ethnic minorities, as well as the United Indian Health Service is another good resource, and it has a whole section for diabetes particularly. So it's important as a student to understand the anatomy and the physiology. So we start with the pancreas, which produces the beta cells and the alpha cells. So the beta cells produce the insulin, and then we have the alpha cells that produce glucagon that stimulates our liver to actually produce glucose. So this forms a homeostasis. So when we eat, the beta cells release insulin to cover the surge of glucose from our food. This is the normal process. And then when we're not eating, our liver releases a small amount of glucose so that we have this homeostasis and we're maintained, and our brain has enough glucose. Also, the GI system also plays a role too, because we have these incretins that help to indirectly stimulate the pancreas to produce insulin when food is ingested. And then our kidneys, just to say that they're also affected by the high levels of glucose, vasculature. So it's important to maintain normal glycemia if possible to prevent like nephropathy, kidney disease, and eventual dialysis. So the classic symptoms, I say the polys, so polyuria, polydipsia, polyphagia, and these are all classic symptoms, but this particular slide as far as age-related changes influencing the diagnosis of type 2 diabetes, where it could be missed because with the older adult, the older female may have a urinary tract infection, or may be thought that she has a urinary tract infection, that's why she's having polyuria. And then as far as men, benign prostate hyperplasia. And then polydipsia, the thirst sensation may be decreased, so that may not be a notable symptom, and polyphagia, decreased motility of the GI system, and also possibly depression, and then even like taste sensation too. Because of these symptoms being missed for diagnosis, it may not be made until something happens, very traumatic, like a stroke or an MI, and then the diagnosis is made. Another atypical presentation for older adults could be like vaginitis or a vaginal itching and erectile dysfunction for men. So the overall goals for diabetes for risk reduction is to promote normal glycemia. We want to avoid dyslipidemias, hypertension. We want to also avoid complications and also the geriatric syndromes. The impact of the comorbidities can impact as far as the various complications and also problems with ADLs or activities of daily living. And we should be encouraged to just make sure patients are doing well with their self-care management because of the impact of these comorbidities. And also as far as functional impairment or disability and history taking, it's important to use screening tools. And a lot of these can be accessed at consult.gerryn.org to get screening tools to make sure patients are doing well and managing their diabetes as well as functioning appropriately. And so we have the impact of geriatric syndromes, so polypharmacy, depression, cognitive impairment, urinary incontinence, persistent pain, injurious falls. So these are various things that we have to screen for and look out for. And it's recommended that we do screen for these in the older adult. And we screen initially and then 3 to 6 months later after a new diagnosis. So before discussing polypharmacy, it's important to realize the sites of actions of the oral agents. And there's like 6 different oral agents, which is nice because probably since 1995 we had, an increase of various medications that we can use. Prior to that, we only basically had 1 oral agent. So we have the sulfonylureas and also the short-acting non-sulfonylureas that affect the pancreas. So it's like it squeezes the pancreas to promote the beta cell to make more insulin. And then we have at the gut, we have a carbose or precose, which actually slows down carbohydrate metabolism. And then we have the incretin mimetics and DPP-4 inhibitors such as Januvia, and these indirectly they do some decreased carbohydrate metabolism. However, they indirectly, because of the glucose surge with eating, also stimulates the pancreas to release more insulin. And then metformin or glucophage decreases the production of hepatic glucose. And we have the TZDs or the thiazolidinones. And the one that's probably the most popularly used is Actos or pioglitazone, and that actually decreases insulin resistance. So we have our various insulins, the rapid-acting insulin, onset 0 to 15 minutes, the short-acting onset half an hour to an hour, and the intermediate, the onset hour to 2 hours. Long-acting, there's an onset, but the nice thing about the long-acting is that it lasts for 24 hours, and that's considered our basal insulin. Then you can get mixed-acting insulin also, where you might have combinations of the short and intermediate, or the rapid-acting and the intermediate-acting. One thing with the long-acting insulin, we don't mix them with any of the other insulins. Long-acting insulin is just given by itself. Another thing, too, is there's different delivery devices. So, some patients, if they can't afford the more expensive devices, the vial and the syringe are used. It's the insulin pens, which are very popular. They're very convenient because they can just carry these pens around with them and dial up the doses. So to learn like some of the newer devices, and even as far as the insulin pumps, if they could just see, because they're going to see patients on these, using these different devices, even the continuous glucose monitoring systems, which are fairly for the past few years, but you'll see more and more patients using these, advanced technological devices. So polypharmacy is something that definitely patients who are older are at high risk for. So it's really important, I think, for the students to have the Bears criteria, which lists meds that are inappropriate for older adults. And there's a variety of other disorders that are associated with diabetes, such as lipid disorders, hypertension, and renal disease. And so patients will have meds for these other comorbid conditions or complications. So it's important to identify and validate that the older adult can recognize the medications that they are on, know what the side effects are. So this study here showed that 37% were given information about the side effects of their drugs, and then there's 20% that forgot to actually take their medications. So if we think about all the meds that patients are on, just briefly, like definitely 7 or more medications. You start with aspirin, because everyone should be on an aspirin if they can tolerate it, a multivitamin, and then studies have shown it takes 3 to 4 medications to control hypertension, and then for their lipids, 1 or 2 medications to control their lipids. And then for diabetes, we have maybe 2 or 4 oral agents. Maybe there's Byetta on top of that, or insulin on top of that too. So it's important to screen. And students can do really nice things as far as med list reconciliations with patients, going through the meds, reviewing the side effects, reviewing the mechanism of action, what they're for, and then just provide lists for the patients. I think that helps to really cut down on medication errors, as well as hopefully providing them with information so that they don't forget to take their medication. This is an interesting study. There were 2,300 older women between the ages of 70 and 78. Half of them had diabetes, half of them didn't. But the ones that had diabetes scored lower on the cognitive test. And they thought that it was due to either casual hyperglycemia or chronic hyperglycemia. Oftentimes we ask which came first, the chicken or the egg, and even with depression, which came first, depression or diabetes and depression. There's such a strong association between the two. Granted, you can develop diabetes if you are depressed and placed on certain medications like Zyprexa, gain weight, and actually, I've seen it where people, being treated for depression have developed diabetes. But it's important to assess for depression because it is a treatable disease. There are tools that you can download, especially for the older adult, the Geriatric Depression Scale. A screening can be done, and also as far as whether the signs and symptoms are present when you screen, and notifying someone to alert them that further evaluation needs to be done. So there's so many factors that can contribute to falls with the older adult with diabetes. I mean, hypoglycemia and just feeling weak and dizzy. Hyperglycemia leading to dehydration and then dizziness and possibly falling. And then neuropathy, orthostatic hypertension, which is a form of autonomic neuropathy. Also peripheral neuropathy of the lower extremities, where patients don't quite have the good sensation of feeling when they're walking. It's funny when you can tell someone that has neuropathy how they walk. So for students, it's really good for them to do a foot assessment to see if a patient has neuropathy, in their lower extremities. The monofilament, the vibratory fork, the reflex hammer, checking for reflexes and so forth. That's where it comes in. So the American Geriatric Society recommends that all individuals with type 2 diabetes be screened for persistent pain. And there's several types of tools that are available for pain assessment. Different facilities and agencies probably use different tools, but this is important to also incorporate into assessment. The thing is with neuropathic pain, it is, again, treatable. There are treatments for neuropathic pain. So with older women with type 2 diabetes at increased risk for urinary incontinence because of the chronic hyperglycemia, older men also, because of the chronic hyperglycemia. Physiologically, this excess glucose can cause shifts in the fluid balance within the body. The chronic hyperglycemia can affect the genitourinary system by causing symptoms of frequency, polyuria, nocturia, people getting up at night 3-4 times a night just to go to the bathroom. And then because of this sensation to go to the bathroom, potentially urinary incontinence. So you can see how hyperglycemia can contribute to polyuria and then incontinence. So screening, again, is necessary in this respect. The natural process of aging, just as we age, we have decreased renal flow, we have a reduced number of functioning nephrons, and this leads to a decreased glomerular filtration rate. And so we have the natural process of aging, and then on top of that, we have the vascular changes that are associated with diabetes. This leads to kidney disease nephropathy. So the National Kidney Foundation, they stage chronic kidney disease stage 1 through 5, and that's all based on the glomerular filtration rate. And we have about 16 million people with stage 3 in the United States, and then we have about 800,000 people with stage 4 and 5, and you wonder, we have all these people with stage 3 and a smaller number with stage 4 and 5, so why? That's because a large amount, or the majority of people in stage 3 actually die of some sort of cardiovascular event. So it's important to optimize glucose and blood pressure control, and also to decrease urine microalbumin. So we have the natural process of aging, the nephropathy, and then we have to think again how the nephrotoxic drugs may affect the kidneys. So it's important to monitor for lab work, also the various medications that are nephrotoxic, and to monitor the dosage. So routine surveillance is very, very important for these medications. So diabetes in itself, I always say, isn't so bad, but it's the complications that come with the disease, the cardiovascular complications, the peripheral arterial complications, and so forth, peripheral neuropathy. So it's important to really try to prevent this damage from occurring. And as far as amputations, it's very common for patients over the age of 65 to start experiencing amputations. And usually when they start experiencing, I say, because they'll start and they may cut, a portion or a toe or something, then it's a little bit more and a little bit more. So to me, it's very sad when people start getting amputations, and then their life expectancy is also sort of cut down too once that happens. So nursing assessment is very important. A detailed history, social and functional assessment, review of multiple systems is important. If students ever have the opportunity to shadow a certified diabetes educator, it's really nice. They could perform a nice nursing assessment, and granted, any newly diagnosed patient in any facility that they're actually working. And then as far as providing a plan of care that's very individualized and very focused with that patient's needs. So the assessment of past medical history is very important, and overall management is very important. The exact age of onset, because you can figure out duration. Also the course of the illness, the progression, how they're doing, how are they controlling their blood sugar, have they been out of control for a long time, is their A1C sort of at target, any management issues that they may have, how are they managing their disease. And paramount to overall management, of course, is the lifestyle with the physical activity. Are they doing aerobic exercise of any type, modest walking in increments, because even incremental activity, 10 minutes of walking, 5 minutes in one direction, 5 minutes back, 3 times a day is still beneficial. And also resistance training too, soup cans, just sitting in front of the television exercising, with soup cans or small weights or bottles of water. And just building, the muscle. The more efficient the muscle is, the better it works. Weight control is important, hopefully with modest activity and good meal planning. A 24-hour diet recall is so important to assess, because patients eat different times. Older patients, I find, eat different times, and they're trying to figure out their medications, how they prepare their food, how much food they're eating, what types of food they're eating. Glycemic monitoring is another important aspect too, as far as reviewing the blood sugar logs, trying to figure out when they're hyperglycemic, when they're hypoglycemic, and how it corresponds to their meds and their food. And then the use of medications is another important aspect of management. Any hospitalizations, why they were hospitalized. Were they hospitalized because of their type 2 diabetes, or were they hospitalized because of a complication? We find that most patients are actually hospitalized because of some sort of complication that ensued because of their diabetes or some other comorbid condition. Again, as far as basic management, we want the patient to reduce glycemia and to control their blood pressure and lipids. So we want them normal glycemic, we want them normal tensive, and we want their lipids normal. So that's the goal. We also want to decrease morbidity and mortality from any acute or chronic complication that may ensue. We also will need some sort of multifactorial risk reduction. Lifestyle, diet, exercise, and pharmacological therapy are, again, all important. So it's 6.5 to 7 is recommended for those who are highly functioning as older persons, and then possibly 8 for those who are frail or have a limited life expectancy, who have adverse diabetes complications or extensive comorbidities. And this was actually recent, like with the A1C of less than 8, the American Diabetes Association in 2009, this January, in their clinical practice guidelines, they recommended that the treatment goals be individualized, especially for the older adult. And there are 2 studies, the advanced study, which showed that a decreased A1C actually was beneficial, decreased A1C less than 6.5, where there was less nephropathy, but then the Accord study had a decreased A1C of less than 6.5, and it was increased mortality. In the population of patients that were in both studies were older adults. So that's why they've sort of adjusted, their thinking a little bit. So the U.S. Diabetes conversation maps are just a tool to use for group education. And I find that my older adults enjoy this. It's like a board game, and it's very interactive. It's very supportive for the patient because they get the support of the other people in the group as we go around playing this and learning about diabetes and learning how to manage their diabetes. So in summary, we see that type 2 diabetes is epidemic in ethnic minorities. Also, it's something that is preventable. Diabetes prevention studies have shown that. the complications can be silent, so it's a need for heightened vigilance and screening. And also, we're just trying to decrease that mortality. And it's multifactorial risk reduction that's necessary to decrease both the microvascular and the macrovascular complications. So again, screening is important. Care visits, ongoing referrals, assessment, and just optimizing control of the blood glucose, blood pressure, and the lipid.
So this concludes our time with Ms. Vanessa Jefferson. I would like to thank her for providing some really good information about diabetes and care of the older adult.